Good evening. Welcome to the Elrod Center for Family and Community on the campus of Ouachita Baptist University, where Dr. Ben Sells is our president. I'm Lewis Shepard Jr., Special Assistant to the President here at Ouachita, and your facilitator for this evening's event. Also, I serve as pastor of Greater Pleasant Hill Baptist Church, a role that I've served in for the previous 20 years, and as a member of the Arkansas Hospice Foundation Board. It is great to be here this evening as we discuss the topic, Black, Brown, and the challenge of dying well. What exactly is Black, Brown, and the challenge of dying well? African Americans, as well as Hispanics and other minorities, are at risk of not dying well. Historical lack of access and substandard health care for minorities over time has led to a general sense of mistrust in many aspects of our modern healthcare system, including the understanding and utilization of hospice care. But change comes with understanding. Knowing what hospice care is and how to assess it can help our minority populations and their families to receive the comfort and respect they deserve when life-limiting illnesses occur. This online workshop is designed to help bring awareness to all our communities about the problems and available solutions for minorities and end-of-life healthcare. Arkansas Hospice is presenting this program, which is made possible by a grant from the Rebsamen Fund. We are blessed this evening to have two experts in this field. Our panelists for this event, Ms. Vinita Marie Giles, who is a native of Girton, Arkansas, born to Mr. Henry I. Bell Jr. and the late Ms. Lila J. Tate Bell. She graduated from Girton High School in 1979. After graduating from high school, she attended and graduated from Ouachita Votech in the LPN program. Later, she attended Baptist schools for nursing, received an RN diploma. And after graduating, she pursued her career at Baptist Health, Little Rock, and later transferred to Baptist Health Center, Arkadelphia, where she worked in numerous positions. Before leaving Baptist Health Medical Center, she served as a night supervisor. She worked at Baptist Health Home and Hospice. And in that hospice setting, she served as field nurse, team leader, supervisor, and later as agency director. In 2017, she transferred to Baptist Home Health, Little Rock, and now serves as hospital liaison for home health. Her career in the nursing profession has lasted over 35 years. Vinita is married to Philip Giles for 39 and a half years, and they are the parents of Nia and Nico Hobbs, and also the grandparents of Kaylin and Niles of Arkadelphia. She is a member of the Mount Canaan Baptist Church, Girton, under the leadership of Reverend Johnny Harris. She serves as a Sunday school teacher, sings in the choir, and is a deaconess. She loves spending time with her family and says she loves the Lord. Thank you for being with us, Ms. Giles, this evening. Our next panelist is a writer, a scholar, a pastor, an activist. Frederick Smith committed to serving God at an early age and entered the preaching ministry at the age of 9 under the pastoral care of his father. There he served at the Canaan Baptist Church in Texarkana in numerous roles at his home church to help develop his leadership skills for the future. And after high school, he furthered his education at Williams Baptist University as a student athlete, graduating in 2008 with an English education degree. He entered the teaching profession as a high school English teacher and coach. In November of 2009, he followed God's call into the pastoral ministry, accepting the invitation to serve as senior pastor at Gennesaret Baptist Church in Arkadelphia. And during his 7-year tenure at Gennesaret, He led the church to mature emotionally, spiritually, fostering several community partnerships to help the low-income families and individuals in Arkadelphia. In partnership with the University of Arkansas Medical School Extension Program, Genezareth established a community garden and offered the Faithful Families classes, program focusing on the holistic approach to well-being of families. In addition to serving as senior pastor, Frederick worked as a chaplain for Arkansas Hospice, a frequent lecturer on religion and culture at the Telford Unit State Prison in New Boston, Texas, and a contributing writer to the Texarkana Community Journal. In 2017, he graduated from Memphis Theological Seminary with a Master of Divinity, concentration in areas of preaching and leadership and social justice. Currently, he serves as a chaplain and bereavement coordinator for Baptist Health Hospice. He is a graduate student at Chicago Theological Seminary, focusing on political theology and pastoral care. Frederick is married to Dr. Samika Smith, and they are the parents of three wonderful boys, Benjamin, Braxton, and Michael. Welcome and thank you for being here, Pastor Smith, as well as Ms. Giles. Well, the question now is, we have two panelists who are experts in their fields, and the question remains, how can you get questions answered that we may not ask on this evening? Well, that's very interesting, very simple. Questions can be forwarded to our panel discussion by visiting arkansashospice.org. And at the bottom of the page is a link where questions and discussion topics can be submitted. Listeners can also submit their questions live during the program. But we encourage everyone to please send your questions in now. I will start our discussion this evening with an open-ended question. It will actually be a request. And since I have known both of these individuals quite an extended time, been very familiar with their families and close to their families through the years and close to them, share with us your hospice story and how you as a minority first encountered hospice care. What is your hospice story and how you as a minority first encountered hospice care? Ms. Giles, would you like to go first?
Okay. Well, I think my first experience was not official as a hospice program per se, but I think in looking back, my first experience was with the death of my firstborn child. And, you know, even though I was a nurse, I could not operate in that capacity during that period of time. It was very hard and emotionally, physically, and mentally draining, as well as spiritually. But my child was transported to Arkansas Children's Hospital, and there I met the doctor, which told us, you know, she's going to die. And that was just simple as that. She's going to die. And gave us the opportunity to spend the time with her that we needed, or, you know, with the information we had, not knowing how this was going to all pan out. But the staff was very supportive, and they gave us the opportunity and opened up the doors to allow us to do that. After the death of the child, my child, then I received information, which, you know, helped me, books and things like that. And I think that probably was the first experience I had that was so close that I didn't know what to do. But yet a doctor reached out and sent me a book that helped me. good things, bad things happen to good people. And so that was started my journey in really looking at um, what hospice or death and dying was all about.
Thank you. And you know, that book by Rabbi Harold Kushner, uh, he wrote that after he had experienced the loss of a child. It really reaches out and appeals to people who are dealing with loss. I guess my first encounter with hospice was through you, Ms. Giles,
Okay.
and with your work there in a conversation one day. And I just want to tell you, I appreciate all that you've taught me through the years. And when I taught death and dying as a class, thank you for always coming and being a guest and sharing your wealth of knowledge and experience. Pastor Smith, how do you respond to your first encounter with hospice as an organization?
Well, for me, I think it was my first encounter was my junior year of college. Our minister of music at my dad's church at that time, I was home for the holidays, and our minister of music, she had a cancer diagnosis that had returned. And my parents had just so happened to be out of town at that time. And so I was kind of fulfilling some pastoral care roles for my dad while he and my mom were out of town. And he had received a call and could not get back. And she was admitted to inpatient hospice care. And so she was doing home hospice care and to the point then where she needed to be in the hospital. And so those kind of last hours of her life, I was there with her and her sons and the remainder of their family. And that was kind of my first encounter with hospice. But then later on, as you know, my late uncle, Chester Kerrigan, after being able to work with him and with some funerals, getting to know families some close families who were members of their church, their Union Baptist Church in Hot Springs, and really getting to understand just the end of life care and what that really meant for me. And before you know it, after I was coming out of seminary, my uncle encouraged me to go and be a part of a hospice organization. And so that's kind of how I ended up on this path there from hospice, just really stepping in a role for my dad. And now here I am fulfilling that obligation still now.
Thank you. In your experience, how have minorities traditionally perceived hospice care? And as I frame that question, I want to give it some context that hospice care goes back to the 11th century. And it was from the Latin word hospes, which means guest or host. And it was considered an inn where people who were at the end of life journeys could come and rest and die in peace. And Dr. Cicely Saunders, who was a nurse in 1948 and started working with this in Great Britain, and in 57 became an MD, and in 1967 founded the St. Christopher's Hospice in London, which was the first hospice for terminally ill patients in the United Kingdom. But it was only until 1974 that the concept of hospice became popular in the United States with the Connecticut Hospice in Branford, Connecticut. So people, as a general rule, tend to distrust those things that do not have a proven track record over many years of time. And since hospice is an organization that has been in effect for 46 years in the United States, speak to how minorities perceive hospice care in America.
Well, I think the first thing, Dr. Shepherd, is that, and again, my experiences helped me to realize how I felt about death and dying. And so people shy away from it, and they don't talk about it because they don't want to think that it's going to happen to them. So you have that resistance to knowing that we're all going to die. We don't know when and how it's going to occur. But I think that because of that, because families don't discuss it and they don't want to talk about it, they just don't even open their minds to really find out how really their families feel about it. So therefore, we don't talk about it, so it don't exist, and we don't have to face it, because whether it's coming sooner or later, I would prefer not to even think about it that's going to happen. So I think it's hard for people to just embrace it and say, hey, it's going to happen. Let's discuss it. It's not just because we discuss it, it's going to make it happen sooner, but we don't know. So I think that families, it's a big thing, especially in the minority families, to talk about it and really know, even if they don't know how they really feel, but yet just discuss it with their family members and say, hey, something happens, or what do you want? Just have that discussion. So anything other than if they think you're going to starve them or anything like that, that's what the myth is, that, hey, I don't, because we like to feed people. We don't want to think that we have to. So what they've heard is that, oh, they're gonna not let you eat. They're not gonna let you drink. And guess what? So they don't want to think of their family having to go through that. So I think that's it's a big thing. And so people just don't want to talk about it, discuss it, or even, so they just said, it doesn't exist. So I think that's one of the issues.
And also that the myth is that your loved one will not receive any medication.
Yes. Mm-hmm.
That is one of the myths that we have to overcome. Pastor Smith, what have you encountered in your work?
Well, in my work, particularly as a chaplain, one of the encounters I have with particularly Black families is the skepticism that we have as it relates to the healthcare system and how we have been treated historically, our experiences that family members or loved ones have had. And so that carries over, that particular mindset, it transitions over into, particularly in hospice care. And so when they hear the word hospice, as Ms. Vinita said, families automatically tense up because this is the end. And so families, I have not ever had that conversation as to what they would desire, or what their loved one would desire to have at the end of life, or if they have had a conversation, they believe with hospice care that they're just going to receive. For me, I've heard families say, "Well, you all will just give them a medicine to help assist them in their transition from this life." And so there's just the lack of understanding or education, or just the willingness to have those very difficult conversations, has led to a lot of skepticism within Black communities, and how we have seen or received treatment, or how we've seen others treated. And so the hands go up. Wait, hold on 1 minute. I don't think I want my family, my mom or dad or loved one, to be on hospice care, because that means there's also an emotional bearing that in just kind of a physical and moral responsibility that some family members may have, because to think, am I just giving up on my loved one to say, well, hospice come in and that's it for them?
And some of my experience has been too, is that spiritually, they think, well, God's going to heal, but they just think physically. And so therefore they think that if they give up on that, then their faith is, lessened. So you have that also, that people really fight that because, mama's going to be healed. Yes. And so to get that to their head sometimes is very, very hard.
Or that we may be rushing God's timing
Yes.
as well. I've heard that the way that y'all are rushing, the Lord has not said that it's time for them to go yet. We rushing them off to be with the Lord. And so, as you say, that those are just the moral, the spiritual faith aspects of it really brings a lot of skepticism to a lot of Black families as it relates to hospice.
When I taught death and dying, we call that syndrome of not being willing to speak about it, the horse on the dining room table. And I got a chance to experience that when, as part of assignments, that I would not give a final in the class, but they had to do a project. And a part of that project was to write their own obituary, complete their death certificate, which was an actual copy, an Arkansas death certificate, to write the announcement for the newspaper, and to write their own eulogy. I was shocked at the number of students who said their uncle, their aunt, their parent told them, drop the class, you don't have to do this. And I said, either you'll do it for yourself or someone will do it for you one day. This horse will get off the dining room table eventually. So we've got a lesson to teach people that this is something that everyone is going to be faced with someday in some capacity, so that to be prepared for it is the best avenue. Our third question, how do we address issues of access to hospice care for minorities? And I know many times that in our southwestern Arkansas region and eastern Arkansas areas, that populations are thinning. Healthcare is sometimes a challenge. It may be an hour's drive to a doctor's office. How do we deal with access to hospice for minorities who may tend to be in these populated areas?
Well, I think one thing is to let families know that they can care for their loved one at home, and the nurse, or the team comes there. And it is sometimes frightening because a lot of times you find out that people really want their loved ones at home, but then they want them not to die at home. So, that's another issue. And then because of the journey that especially if it's inpatient, getting somewhere close that they can visit their family members and just, I think we need to network in areas where there's a hospice that's not close by that may get that referral, is to reach out to those that may be close to the area, which that would decrease some of the anxiety of, having your loved one to, being without some care, even though people live in different areas. But I think to operate or hook them up with somebody close within that area. But of course, we know people have choice to pick whom they want. But, I think with me, a lot of times in the business, in my past experiences, that we have to have patience, true enough. But I think what is the best interest for the patient? And so therefore, I think a lot of the access is not there. They think about how long it's going to take, how far away is the patient or the nurse is going to be from them. So therefore, I think a lot of people shut down with that too, because the access is not readily available, because they think it's going to be like in the hospital where it's going to be 5 minutes before someone gets there. And so that makes people shy away also, because that's too far. And I'd rather just have them rush them to the emergency room or something like that. So I think that we have to be more visible to let them know what's available to them out there, what areas that particular agency or hospice covers, and where they're located to better inform them that, hey, you have the availability, but it's just the message getting out there because, it's a lot of people still don't know what hospice is. They don't know, you may ask them, what is your experience? And they're like, oh, I just heard this. So it's very important that we get that word out there that there is somebody for you and you have access to it just like anyone else.
I think within the key of that, I often say people could care less about what we have to say until we have concern about where there are.
Yeah.
And one of the key aspects, I think a great point Ms. Vinita brought out is that the networking and ensuring that if there's a hospital or a hospice organization who is nearby, who is providing marketing tools and marketing in those particular communities and providing education opportunities. I would even think as a faith leaders have a responsibility. If we're talking about discipling your parishioners in your faith community, you have almost a responsibility to disciple your people who you lead, how to think about dying, how to think about the end of life, about dying well. And one of those keys in a platform such as this, what we're doing is educating, but then also being very intentional and reaching out to a hospital or a county hospital or looking up now. There's so much access on the internet where there's a wealth of information and seeing who is there and who you can contact and bringing them in and help educating the community about what is available as it relates to end of life care and comfort care when it comes to hospice. And so those are some things I think we can do as it relates to networking on those who are on the hospice side, but then the intentionality of discipling to die well on those who are leaders in faith community.
Thank you. In a recent survey, 55% of the people surveyed said that they did not know how hospice is paid for. How is hospice paid for?
Well, Medicare, you have the Medicare hospice benefit and also Medicaid. And there had been, and someone may correct me if I'm wrong about that, some private insurances will have that ability to, provide that for their patients. So that's what I know of as my last information for as the Medicare hospice benefit and also Medicaid and some insurances had that hospice where they'll pay for it.
And there are some insurance companies who provide just long-term care as well that may be separate from a primary insurance agency that a family may have. So there are insurance companies who are out there who do provide that for you.
In order to get provide access for families who may be needing the services of hospice, we've got to get the information out to the general public. How can hospice organizations make some inroads, make more inroads to better serve minority communities? What do you see as some avenues that we can go out and spread this gospel of good news that you don't have to go down this journey by yourself, that we've got people who are trained, who are sympathetic, that you can call day or night to be with you? How do we get that word out there?
As Reverend Smith said, I think one of the avenues is the church and just different organizations that meet to students. Like we said, Reverend Shepherd, I've spoken to your classes. And so I think that that's very important. But as Reverend Smith said, the church and just talking to, people who may have experienced it. Because again, people, you can talk all you want to, but a lot of some of our business come from word of mouth. So if I've serviced this patient and given them good service and cared for them and provided them with a positive experience as best it can be in the situation, then they're going to tell somebody else. But it depends how we approach the subject, how we talk about it, and lay it out for our minority people. We need to be upfront and, like I said, be available to give them that information at church, even schools, because not only are older people dying, but young people are dying also. So if that could happen, that would be great to start that, outreach.
And now within the age of a pandemic and COVID, we have access now to digitally communicate messages, right. and being very intentional about that. But then also even understanding, as Dr. Shepard, as you raised the issue here just a few minutes ago, there are areas who may not have access to this kind of information digitally, because of the socioeconomic issues within that particular community. And so I think agencies really have to be very intentional about building those relationships within that area. If it means going to a barbershop and just kind of building relationships there, taking the time to really care about where the people you're desiring to serve, being very intentional about positioning yourself where they are and getting your message. And as Vinita said, it's so key to ensure how you approach that subject is very vital to whether or not a family is going to be open to saying, yes, we want our loved one to be on hospice care. I'm very intentional when I'm helping talking with families about making a decision to come on hospice care with our agency at Baptist, to let them know this is a journey and we're here with you. And particularly with Black families, I'm very frank and upfront. I understand your skepticism, your hesitation of your hesitancy of why you do not want to make this decision. But I try to be very as honest with them, what this means and what that process will look like, that we're on a journey together to ensure that your loved one can transition from this life to the next with peace of mind, and for the loved ones as well. Because it's just as hard on the caretaker as it is for those who have been diagnosed with a long-term end-of-life illness.
And you have that support. Hospice is not just there for that time being. They follow and they provide that support that family needs. And even though I'm not on the end of hospice per se, but I always, when I talk to families, if they open that door, I walk through it and just say, well, have you thought about this? What is your plan? Because a lot of times people don't know where to go, and they've not always gotten that information from their physician or whatever. And they just know they're just following what the doctor said. And if they say come back in 3 months, then they come back in 3 months, and knowing things aren't getting any better. So they think that's what they're supposed to do. And so when you find that, you have to just say, okay, how are you feeling about this? And maybe walk into it, not just, jump on them and just start, giving them this heavy duty spiel. But I think you have to have a sense of what the atmosphere is like when you go in and talk to a family. When they're, just very resistant versus when they are really inviting information, and we have to know where to cross that line and start talking, having a discussion with them. Perfect example, my dad was taking him to the doctor every 3 months. and there were no changes. I mean, he was getting older. He was 90-something years old, and he kept going back to the doctor every 3 months. And I'm like, okay, Dad, it took him longer to get him in the, in the doctor's office by wheelchair and just dragging him in there. And I said, okay, so what are they changing? Oh, nothing. I said, so what is the plan? Because he's going down. And so anything he does is not going to get in, make him better. He's just dragging him in here every 3 months. And he said, okay, bring him back another 3 months. Uh, just talk to him and see if we can't just take care of him at home. And, but a lot of times families are afraid to ask, or they don't know to ask. So therefore, it's not said. And before we know it, hospice is called in at the last minute when you can provide service, but they don't get the full benefit of the service they could have gotten in support if, we would approach that a little early and have that discussion.
And I think that's even important because if you're able to be educated on hospice care, both of us can testify to this, where it has helped the quality of life towards the end of life, where someone who may have received the diagnosis of, hey, you only have a month or two. Well, when hospice care came in, maybe in an earlier time, it helped prolong that time, and at least where loved ones were able to kind of still enjoy a few memories before their loved one transitioned. And so just really sensing the room is vitally important, because it really helps you to connect, to get beyond the fact, yes, this is a business, and hospice agencies make money based on their patients. But at the same time, we are in the care profession, or in the care ministry. And that has to remain, as you say, you have to keep the main thing the main thing. And so that is vitally important, and for communities, particularly Black communities, understanding we're here to walk with you through that journey. And the main thing is ensuring that your loved one has the best quality of life towards the end of life. And then you have that support that you're going to need walking not only to that point of transition, but even beyond that, in providing bereavement support for you.
In many of our rural communities, we no longer have daily newspaper, and sometimes not even weekly newspapers. We no longer have radio stations. Is it insensitive to place information on hospice care in doctors' offices?
No, because now people have to market, and that's what they put brochures out, and it's just simply maybe further discussing with that person who's in charge, like the office manager or something, that, hey, these are for the patients and families. If they ask, or you feel like that, they're ready for that point, you can tell them, along with other brochures, like whether it's personal care or home health, that these are the brochures and these are the resources available to you. So I think it's possible, but it's all in how you present it, and sensing where they are in that, as I say, cycle of life, because that's what it is. It's a cycle. And so what you see a lot of times, people just back and forth to the hospital, they, not getting any better. They can't offer any other aggressive treatment that would not even, they can prolong it for a little bit, but it gets to be a cycle. They're back and with the same thing, and the symptoms are worse. And so I think that would be key, is to have those that resource information available.
We have a question that has come in, and that question is, has the pandemic made it more or less likely that African American families will consider hospice care? How has the pandemic affected hospice care in the African American communities? Is it more likely or less likely that services may be sought now?
Well, with me, I'm thinking that even not only with minorities, but people in general are kind of scared for people to come into their homes because that we need to make sure that they um, know that we are going to protect them as much as possible, but by following those guidelines that are set before us, and let them know that we have to follow those guidelines. And then to let them know that I think the consistency of the same person coming in to see that patient and families make it so much better because they don't have to get used to a stranger or wonder if they're okay or anything like that. So I think if we assure them that we would try to the best of our abilities to make that happen, whether it be home health or hospice. I think that's a concern for everybody at this time, and it is. We do find a lot of patients I know, especially in home health, that will not take the services because of that fear of the COVID, the pandemic.
Yeah, I've been noticing that the pandemic has really, it's not just Black families who are saying no or who are very hesitant now. And one of the strategies that we have been using, I know in the team that I work with, uh, it may just be the nurse who's coming in or the aide. So myself as the chaplain or the social worker, we've been having to do telehealth ourselves. So and just kind of communicating, hey, we're still going to be here for you. If you're not comfortable with us being who's a part of this particular team who will come in, that's fine. We just as long as the nurse is in there and you're receiving the care and your loved ones receiving the care they need, that's perfectly fine. But if it needs to be that we have to receive the care through telehealth or over the phone, however we need to do to make sure we're there with you on the journey, that's kind of one of the things I've been seeing from all ethnicities right now.
In your opinion, does the current cultural climate, racial and political tension, have an adverse effect on minority outreach regarding hospice care?
I'll put that to Reverend Smith.
And I know this may be hard to delineate from COVID-19 because both of them came at about the same time and invaded our communities at about the same time. So it may be hard to distinguish, but have you noticed any particular events or conversations that you may have
had? I've had several conversations where I've had to enter into homes where family members are on different sides of the political spectrum. And so it creates some very exciting conversations, I say the least. But at the same time, the opportunity to hear and to the opportunity to open, it's not my responsibility to open anyone's eyes, but yet to present an alternative perspective, a fresh perspective. And so it hasn't necessarily for minorities. I believe it just really depends because let's be honest with the current political climate the way it is, there is skepticism about anyone who is Anglo-Saxon walking into our home. Do you support an individual who has intentionally blurted racist comments, put forth racist policies? And even if you are not stating that, the way you're handling me, the way you're speaking to me, is that portraying that type of behavior? And so I work around some wonderful individuals who go into the homes and are able to treat people as with human dignity. But at the same time, myself or some coworkers, we've entered into homes and we have been on the other side of having to have the very difficult conversation and saying, I'm here for care. Yes. Now, for me, as a chaplain and providing pastoral care, a lot of times I'm there to just listen. So I'm going to have to hear a lot of conversations from family members, be it whatever, if they're of a different opinion of myself and how and what I'm seeing in society. But for a lot of Black families that I'm engaged with, they may pull me to the side and ask me, how do they think about us or how do they perceive us? And so I kind of alleviate their fears. You're okay. You're in great hands. And at the same time, even if not, I take the time to speak with some of my coworkers. Have you considered how you're speaking with this individual? Because here is how it may be perceived based on myself being a Black man and understanding and hearing conversations that you may not hear. And so I think it's important for me as well to be in a position to speak truth in love on both sides, whoever it may be.
Thank you.
And I think in a lot of instances, we've had, as minorities, going in homes of various, races, race of people, then, sometimes, our purpose for being there is perceived as less than what we're there for. It's almost like, oh, you're the aide. No. So, you have to stand your grounds and yet be sensitive, but therefore not be intimidated. And, handle that with sensitivity, but yet, let them know that, you're there, as Reverend Smith said, to provide care. And, yes, I've been in situations where words have been, the N-word's been used, and you just kind of look at them and say, okay, oh, I wasn't talking about you. Well, who were you talking about? But that's okay. I'm here to take care of you. I'm going to still take care of you no matter what, or what your, political beliefs are. I'm not here to, try to sway you in that way, but I'm going to do my job. And, you just have to, as Reverend Smith said, go in love, because no matter what, we've taken an oath to do what, to take care of people, no matter what, race, creed, or color, religious background, or anything like that. I am supposed to provide that care. And if I can, then I need to remove myself and allow someone else to do that. But as in, our Black people, we need to know that we have certain rights and we don't need to be treated in any kind of way or feel like we're getting less care. And if so, we have the right to complain or address that with the appropriate people. But, sometimes it get kind of rough because we think, oh, are they trying to do this, and this to me? Because in the history of we have been on the less end of getting what we need in some instances. And we feel that, and it's nothing wrong with saying that. But, sometimes we think, oh, well, we'll just take whatever. No, just as your counterpart deserves the best of care, you do too. And we just need to make sure that relate to them and let them know that.
Richard Rohr states in a book of his that you cannot heal what you will not acknowledge.
And so that's right.
And I think at times it is required on minorities as well as those who, as well as individuals who are Anglo-Saxon, whatever ethnicity you may be, to acknowledge. If you're not acknowledged to the person that you're serving or being served by, at least acknowledge that this is why I am and how I feel, and be very frank and upfront about that. Because I think it's also very important to know that just a few weeks ago, I had kind of one of these conversations with a patient, and the patient had one particular belief, but in the home around her, everyone else had another particular political belief. And she and I found ourselves engaging in a very long conversation about how to handle that, but more so, we also had an opportunity to talk about books that both of us were reading at the time by a particular favorite professor of ours. But within that conversation, it allowed her family to, oh, I can see a Black man in a different light, in a different perspective than what's being fed to me through the media. And so I think that's vitally important for me whenever I'm going into a home as a Black man, to understand I know who I am, I know where I stand, I know what God has called me to do and how to serve in this moment. And so I cannot even let my own political beliefs to interfere what God may want to do in that moment and how he wants me to provide care as a chaplain in that moment. But at the same time, I think Black families, as Ms. Vinita just said, we have to be able to acknowledge, yes, we have experienced a lot of great harm in this country through the medical system, through the healthcare system. And we're still having to overcome, particularly in our state, when Black women are more likely to die giving birth to children. And there's just other various facets and statistics that are out there. And so I think as a Black community, we need to acknowledge these factors and be honest about it. Why we may feel hesitant about someone from hospice care or from a healthcare agency coming in providing us care, because this, as we're able to be very honest about that, our truth, perhaps maybe this opens somebody's eyes and their heart to come stand with us in our truth, because we've acknowledged our truth, but we cannot allow our truth to dictate our emotions.
Exactly.
Yeah.
Thank you for your candidness, your honesty, and your sharing of your expertise with us this evening as we dealt with these questions. I did find some additional information on how hospice is paid for, and the response was commercial and charity care is available to help with that. And I think we mentioned some commercial care with the use of lifelong and long-term care. Thank you for taking the time to spend with us this evening and in our audience. We thank you for tuning in to be a part of this discussion. And I'd like to say a special thanks to the Arkansas Hospice Foundation, the Minority Outreach Coordinator, Reverend Kyle Jones, for their coordination of Black, Brown, and the challenge of dying well. We would like to thank the Rebsamen Fund for making this possible. Without their generous donation, these series of workshops virtually would not be available and possible. Please visit the other pages of arkansashospice.org. Feel free to call or email them if you have any questions or thoughts concerning the services that are being provided. This is the second workshop on this particular topic. As we move regionally around the state of Arkansas, other workshops will be announced. And again, thank you, Pastor Smith, Ms. Giles, and to our audience for tuning in. Again, the Rebsamen Fund for your support. We thank you. Have a good evening, and may God bless and keep each of you. Thank you.